Rheumatoid arthritis is fundamentally an autoimmune disorder where the body's immune system erroneously targets its own tissues. This autoimmune response triggers persistent inflammation, resulting in pain, swelling, and progressive joint damage. Over time, uncontrolled inflammation can result in cartilage destruction, bone erosion, and functional disability. The joint is a complex structure composed of multiple interacting components. Bones form the skeleton framework, while cartilage cushions their articulating surfaces. The joint capsule encloses this structure, lined internally by the synovial membrane. This membrane secretes synovial fluid, which reduces friction during movement. Surrounding muscles provide stability and enable motion. In rheumatoid arthritis, pathological changes profoundly alter joint architecture. Chronic inflammation of the synovial membrane leads to hyperplasia. Concurrent bone destruction occurs through osteoclast, while muscle wasting, or atrophy, develops due to chronic inflammation and disuse. Together, these processes culminate in irreversible joint damage and functional impairment. Typically manifests initially in the small peripheral joints, particularly the metacarpophalangeal and proximal interphalangeal joints of the hands, and metatarsophalangeal joints of the feet. This distal presentation is a hallmark diagnostic feature. As the disease progresses, inflammation spreads proximally to affect larger joints such as wrists, elbows, knees, and ankles. This centripetal pattern of joint involvement reflects the systemic nature of the autoimmune process. In the affected joints, the immune system mistakenly attacks joint tissues. Key immune cells like T cells and B cells become overactive, releasing inflammatory factors such as TNF-alpha and IL-6. These factors cause swelling, pain, and damage to joints over time. Inflammation causes excessive accumulation of synovial fluid within the joint. This fluid buildup creates pressure, leading to the characteristic morning stiffness and discomfort. As inflammation worsens in rheumatoid arthritis, the synovial membrane thickens abnormally, forming invasive tissue called pannus. This aggressive growth releases enzymes that gradually erode cartilage and bone, causing permanent joint damage. When joint inflammation persists unchecked over time, it leads to irreversible damage. Cartilage breaks down, bones erode, and tendons weaken, ultimately causing visible deformities, resulting in significant disability. To summarize, rheumatoid arthritis progresses through 4 distinct pathological phases. In phase 1, immune-mediated synovitis occurs as the body mistakenly attacks the synovial membrane, causing painful inflammation. Phase 2 sees the development of pannus, an abnormal invasive tissue that grows over joint surfaces, releasing destructive enzymes. By phase 3, fibrous ankylosis develops as the joint space fills with scar tissue, severely restricting movement. In the final phase 4, bony ankylosis occurs when this scar tissue ossifies, permanently fusing the joint and causing complete loss of function. Affecting millions worldwide, with prevalence showing a steady increase. In 2020, approximately 20 million individuals were living with RA. This number rose to 20.5 million in 2021, reaching 21 million by 2022 and 21.5 million in 2023. This upward trend highlights RA's growing global health burden and underscores the need for improved management strategies. With women being 2 to 3 times more likely to develop RA than men. This increase may be influenced by hormonal factors, genetic predisposition, and differences in immune system regulation. The development of RA is influenced by several key risk factors. Age plays a significant role, with incidence increasing steadily after 40 years. Gender is another major factor, as RA is far more common in female. Genes play a role, particularly in individuals carrying the HLA-DRB1 shared epitope. These combined factors contribute to the complex etiology of this autoimmune condition. Presents with distinct clinical signs. Swollen joints are visibly enlarged due to synovial inflammation, often accompanied by debilitating fatigue that impairs daily function. Patients may experience low-grade fever. The hallmark symptom is persistent joint pain, typically worsening after periods of inactivity. Characteristic morning stiffness lasts more than 30 minutes, distinguishing RA from mechanical joint disorders. These symptoms collectively signal active autoimmune processes affecting multiple joint systems. Diagnosing rheumatoid arthritis requires a comprehensive approach combining clinical evaluation and diagnostic testing. Imaging plays an important role in diagnosing and monitoring rheumatoid arthritis. X-rays are routinely used to monitor disease progression, revealing characteristic joint erosions and space narrowing over time. CT scans provide detailed assessment of bone damage severity, particularly in complex joints. While not routinely required, MRI offers superior soft tissue visualization, detecting early synovitis and bone edema before structural damage appears on X-rays. When rheumatoid arthritis progresses unchecked, repeated joint failure leads to severe complications. Systemic complications include gastrointestinal problems frequently occur due to medication side effects, leading to chronic stomach and intestinal distress. The lungs are particularly vulnerable. With pulmonary inflammation, patients face a 50% higher risk of coronary ischemic heart disease due to chronic inflammation accelerating atherosclerosis. Non-pharmacologic approaches are important in comprehensive rheumatoid arthritis management. Therapeutic exercise programs are tailored to strengthen periarticular muscles, improve endurance, and maintain joint flexibility while protecting inflamed areas. Adaptive equipment, such as ergonomic tools or mobility aids, helps preserve independence by compensating for functional limitations caused by joint damage. While no specific diet cures RA, an anti-inflammatory eating pattern emphasizing whole foods, omega-3s, and antioxidants may help modulate disease activity and improve overall health outcomes alongside medical treatment. Precision pharmacologic therapies tailored to each patient to achieve remission, prevent joint damage, and maintain long-term physical independence. Pharmacologic treatment primarily involves two classes of disease-modifying anti-rheumatic drugs, or DMARDs. Non-biologic DMARDs, such as methotrexate, are synthetic medications that form the first-line foundation of RA treatment. These systemic drugs work by broadly modulating immune activity. In contrast, biologic DMARDs, like tofacitinib, are complex molecules derived from living cells. They target specific inflammatory pathways with precision, typically reserved for patients with inadequate response to conventional therapy.